I welcome you. My name is Dr. Abbas and I'm a consultant physician, endocrinologist and diabetologist based in Dar es Salaam, Tanzania. I'm a president-elect of DFoot International and regional chair of English-speaking region of Africa. I'm honored to have this opportunity to chair this session. And with me today, I also would like to introduce Professor Maimouna from Dakar, Senegal. She is a current regional chair of French-speaking African countries, and she is going to be with us for all this session as my co-chair. Hereby, I welcome you all for the first educational webinar series produced by DFoot International. We are privileged to have the honor of commencing the first educational session of flagship project of DFoot International here in Africa, which will be the first of the 7 planned webinars in 7 global regions that will occur during the coming weeks. This first webinar from Sub-Saharan Africa will highlight the DFoot International theme for this year and the rest as well, that is Global Act Against Amputation, as the part of ongoing endeavor to enhance awareness regarding issues related to diabetic foot complications. Subsequently, webinars for the 6 remaining regions will run over the course and ending with a grand finale on 14th. Today, we have 7 speakers from Africa, and we welcome all of you, all. I now have a privilege to introduce the president, our president of DFoot International, and his live. So we are not going to see his video. His live is DFoot Dr. Vijay Vishwanathan, who will deliver a message from directly from India. Dr. Vijay.
Thank you, Abbas. I think, as you said, you are the opening player for our DFoot International Diabetic Foot Awareness Week. Tomorrow we have South America and Central America. Following day we have North America and the Caribbean islands. So like that we have arranged the whole week, and on 14th we have a grand finale where we have a galaxy of speakers, and it will be a global program, and that will be at 1 p.m. GMT. So the purpose of DFoot, the DFoot's main mission is ending avoidable lower limb amputations due to diabetes worldwide. Ending avoidable lower limb amputations due to diabetes worldwide. That's our main mission. We are headquartered in Belgium, and we have people from all countries, practically all countries. We have 7 regions in the world from where we operate. We have North America and Caribbean islands, SACA, which is South America and Central America. We have Europe, we have Africa, Sub-Saharan Africa. We have the MENA region, which is Middle East and North Africa. We have Southeast Asia, and we have Western Pacific. And we would like to welcome Professor Hari Krishna Nair, who's our board member, who is from Western Pacific area, who's there in the delegate list. So the purpose of this program, the event, is to create awareness across the globe on diabetic foot. And we want to hear experts. We are all experts in our own way, though the guidelines are written in Europe or United States. But we are all experts in our own way. And we treat a lot of patients with diabetic foot infection. And our experience counts. It's not that our experience doesn't count, it counts. That's why the DFoot is there. The DFoot likes to learn from every person who's practicing diabetic foot, the field of diabetic foot from across the world. So I'd like to thank Abbas and Maimouna for taking the lead for the Africa region and starting this week's program. And we have a lot of plans for the future. We have the current board, which consists of Abbas as the president-elect, Miriam Botros she's the CEO of Wounds Canada, who's our board member. We have Professor Hari Krishnayar, who's attending this particular program from Malaysia, and he's a main person behind Wounds Malaysia. Then we have Nicholas Papanis from Greece, who is also uh, our European counterpart, I should say. So because though Europe is well developed, we thought we should have a European counterpart. And then we have Linda Pedrosa from Brazil, who's our board member. So thank you, Abbas and Maimuna, for taking the lead. And I would like to welcome all of you to this Diabetic Foot Awareness Week being conducted by D-Foot International. Thank you, Abbas.
Thank you very much to coming live and physical. I really appreciate it and really thank you very much. Okay, so we now go with our program. I will hand over to Maimuna as my co-chair to take. Maimuna, please. Unmute, Maimuna.
Yeah. Thank you very much, Abbas. Thank you very much, Vijay. This is really indeed a great opportunity for us, for Africa, to say what we have much to say about diabetics in general and diabetic foot in particular. We also have big hopes, great hopes, but we have no doubt that with you as president, with Abbas as vice president, and the whole team, we will make significant changes. So thank you for organizing this. I'm going to introduce first my brother, Abbas, Dr. Abbas. Dr. Abbas is a consultant physician, endocrinologist, and diabetologist in Tanzania since 1992. He's a fellow of the Royal College of Physicians and Surgeons, Glasgow, and Royal College of Physicians, London. He is currently president-elect of D-Foot International and chair of Pan-African Diabetic Food Study Group, executive board member of International Consensus on the Diabetic Food of IWGDF, and vice president of Association of International Medical Salvage of the Extremity. Dr. Abbas was a founder member of D-Food International and former vice president of D-Food International, founder member of the Step-by-Step Food Project that started in 2003 in Tanzania. And so far, this project has been implemented in 110 countries. He's also a member of the editorial boards of several international peer-reviewed journals published extensively on the epidemiology of diabetic limb complications, and among the first to characterize the burden, microbiology, and public health implications of diabetic upper and lower limb sepsis in Africa. So this is a great job, Abbas. We are aware that still a lot needs to be done, and I will just hand over to you to make the first presentation. The floor is yours.
Thank you very much. Thank you very much. Once again, thank you very much, Maimuna, for a nice words. Thank you. My talk today is Charcot arthropathy is becoming an emerging problem of developing world. As we are aware that Asia, Africa and Asia are two largest continents in the world, and they almost covers about 76% of the population. So we're still in underdeveloped country with a huge number of population, and we have 80% of diabetics coming from this region. Rest of the world covers 24%. So we're going to have a double burden. Charcot arthropathy, the objective is to early recognize and early to refer. What is about Charcot arthropathy? It is a condition without a definition, a condition difficult to diagnose, leading to a major clinical problem, suffering, mortality, and cost. Condition without diagnostic test, a condition with no specific treatment up till now, apart from offloading, and a condition where management hampers by widespread still professionals' ignorance. So let's talk one by one of each. Charcot arthropathy is a progressive disease of a musculoskeletal system that is characterized by dislocation of joints, pathological fractures, and severe deformity. Commonly occurs in weight-bearing joints. Over the period of time, bones become weak, break, and joint can dislocate, leading to deformity. And this deformity of the foot can lead to an ulcer. And once we have an ulcer in our part of the world, it's infection, high morbidity, and even mortality. Diabetes is now considered the most common cause of Charcot arthropathy. Before it was syphilis, occurs at around after 8 to 12 years of diabetes. And now we see our people do live longer, so we see these complications. Fifth and sixth decades are the common cause of Charcot foot. Men are more frequently affected than women. Prevalence globally it ranges from 0.1 to 14%. Bilateral Charcot foot in less than 5% of the people. And in Tanzania, we did study with Charcot foot with ulcer, 14% of the people. Pathophysiology of Charcot foot still not known, but two theories have been put forward as follows. There is continuous neurotraumatic, that is continuous injury to an insensitive foot, severe neuropathy, and continuous ambulation and microtrauma. Second one is neurovascular or autonomic neuropathy, causes more blood flow. This leads to a bone synthesis and destruction, which is leading to osteopenia. Study done in Tanzania shows the Charcot with presence of sensory or autonomic, and injury and trauma are the most important precipitating factors which I mentioned. And in our cases, we found that these were the precipitating causes: blisters, callus, spray, red bites, blunt trauma, and burns. And the percentages are there on slides. Let's go to the second one, a condition difficult to diagnose, leading to a major clinical problems, suffering, morbidity, and mortality, and the costs are high. It all depends on the extent and the stage of development of the Charcot foot. Symptoms can vary from, for example, from a slight swelling of the foot, but to no deformity at all, and to be seen to be a significant swelling and with moderate to severe deformity of the foot. Acute Charcot foot will always be present with the signs of inflammation. There is a swelling of the foot, increased local temperature of the skin, redness, joint swelling, changes seen in the bones in sensitive foot, in insensitive foot, and this presentation with skin still intact, no ulcers, but with loss of sensations are a pathognomic of acute Charcot arthropathy, as you can see on the slide. So a person present with a swollen foot with a bit of aching discomfort for a few days, starting suddenly, maybe after minor trauma or else for no reason. And this can be suspicious in a diabetic patient as a Charcot foot. I will tell you later on. Presentation of Charcot foot in developing world. Charcot foot is misdiagnosed as cellulitis, soft tissue infections, deep vein thrombosis, sprain or gout. It is also reported in the literature in developed world, 80% were misdiagnosed as a sprain, osteomyelitis, deep vein thrombosis, cellulitis, or even rheumatoid arthritis, which are commonly seen in developed world. Charcot arthropathy, deformity or bones destructions not picked up on for foot examination, therefore not managed, ideally leads to severe deformity followed by an ulceration or on a bony prominence. And ulcer on the foot can get infected, necrosis leads to amputation of lower extremity and could be even severe to the life. Rocky bottom foot is a complication of foot deformity which have a collapse, inversion of plantar arch. So this is typical example as a classical case of rocky bottom foot deformity with dislocation of the medial cuneiform and resulted deformity. And there is also a pressure ulcer, as you can see. Or it can appear like this with dislocation of the whole ankle joint, secondary ulceration over the pressure areas. Let's go to the third, a condition without diagnostic test. So we have a laboratory test for a white blood cell count, which differential. However, the WBC count is a non-specific marker for inflammation and can result and may be elevated in any patients with Charcot arthropathy. ESR, however, it is also a non-specific marker for inflammation. Glycolated hemoglobin indicates the level of hyperglycemia due to uncontrolled diabetes. Levels of alkaline phosphatase, calcium, phosphorus, parathyroid hormones can help physicians to identify other bone diseases. Plain radiography, as you can see on the image, are used for the following purpose: to help and stage the Charcot foot disease, to help to determine if the active disease is present or if the joints are stable, to help identify the osteopenia, periarticular fragmentations of the bone, subluxations, dislocations, fractures, or any generalized destructions, all can be seen on plain simple X-ray, which is available everywhere in the world. Whenever possible, radiograph should be obtained with a patient bearing weight. Bone scanning may help to differentiate between Charcot arthropathy and osteomyelitis, and MRI allows anatomical imaging of the area, may help distinguish between osteomyelitis and Charcot foot. Probe to bone is done if exposed bone is infected, diagnosed of osteomyelitis. Portable infrared thermometry is used for a skin temperature and used to monitor active inflammation. There will be a difference of about 3 to 5 degrees seen as an acute Charcot. Joint aspiration is used to rule out septic joint, and synovial biopsy can be helpful to see the small fragments of the bone cartilage which are pathognomic of Charcot foot, whereas other state it is highly suggestive of Charcot arthropathy. Numerous classification systems have been based on clinical radiography and anatomical physiology to describe Charcot foot. Anatomical classification systems are the most commonly used now and have been added to benefit of the predicting outcome and prognosis. So this is one of the broad sky anatomical classification of Charcot foot, and I won't be going into detail, but if you say type 1 midfoot, type 2 hind foot, 3A ankle, 3B calcaneus, when there is a multiple regions involved, 4 and type 5 is forefoot. This is a condition with no specific treatment apart from prolonged offloading. So treatment of Charcot foot is initially non-operative. The treatment takes place in 2 phases, an acute phase and post-acute phase, and management of acute phase includes complete immobilization and stress reduction. Medical therapy, usually immobilization, is done by casting. Total casting is a gold standard treatment, as we all know that. Once total contact casting has been done, there should be a check weekly to assess the correct fit and should be replaced every 1 to 2 weeks. Patients with diabetes and ulcer change on weekly basis to evaluate an ulcers and debridement if needed. Casting is usually required after 3 to 6 months and is discontinued on the basis of clinical, radiography, and temperature checking. Total non-weight bearing is preferred for the treatment. However, patients often do not comply, and especially in our part of the world, with this treatment. This is typical example of total contact cast, and you have also this a special airbag cast. Medical therapy, partial weight bearing can assist like crutches and walkers. Management after cast is removed includes a lifetime protection and to the affected extremity and needs to be offloaded. Regular patients' education, professional foot care is an integral part of ongoing foot protection. Other therapy, use of biophosphonates. These are potential inhibitors of bone resorptions that have a minimal effects on bone formation. This action stops the osteoclastic activity of bone breakdown, promotes healing, and decreases local inflammation. However, only few cases have been reported to have examined this treatment as an alternate. Use of low-intensity ultrasound. Low-intensity ultrasound has been shown to transit mechanical force and strength to the fracture site and promote the bone formation. Studies have demonstrated that acceleration in healing and increase in strength at the callus site. Finally, use of electrostimulation and of magnetic field therapy to stimulate the bone formation has been discussed in a few cases reported. These therapies have shown some benefit in accelerating healing times. However, there is no prospective studies indicating the positive effects of any treatment. Healing times are increased in patients with diabetes. Location of the disease also affects the outcome. Forefoot arthropathies heal in less time than midfoot, hindfoot, or ankle arthropathy, as has been illustrated. The extent of the injury also affects the healing time. The more severe the injury, the longer time it will take to heal, the greater likelihood of permanent deformity. If generally takes 1 to 3 years to complete heal Charcot foot and from an active phase to quiescence phase. So this is where this is one of our patients where we had made a special footwear at an orthopedic institution, and this is what you need to offload with a special footwear. This slide is the next one which demonstrates the importance of the soft tissue inflammation. The picture was taken when the disease was active, and then after 2 years later when the disease was quiet and soft tissue swelling had gone, but deformity still persists. Then surgical intervention. In less than 25% of the cases, we need to go for surgery, and most of them practice preventive measures. Aim of surgical intervention is to reconstruct a step and a stable foot, which can be protected by footwear when patient is walking. When non-operative means fail, surgery is indicated for fracture or dislocation. Early surgical treatment is better than medical treatment. So earlier the better outcome. Now the last part, the condition where management hampers by widespread still professional ignorance. Here a patient present with a swollen foot with a bit of aching and discomfort. So the diagnosis is made whether it is a sprain or a cellulitis or a gout or a DVT. And none of them is true unless you have this find. F for foot, I for inflamed, neuropathy, M for neuropathy, and a patient is diabetes. If you have this, find it. If you have this, then this is Charcot unless proven otherwise. So prognosis of Charcot foot depends on early diagnosis and treatment. A good outcome is most of the time seen when joints are diagnosed correctly and early, intervene and managed properly within 14 days of injury. It also depends on the locations of the disease which affects the outcome. If the injury is severe, it might take longer to heal and chances of permanent deformity would be there. What is the key message and a take home? A condition without a definition and without a diagnostic test, a major clinical problem, suffering, mortality and high cost. There is no specific treatment apart from prolonged offloading which has to be started earlier. Management hampered by widespread professional ignorance, and all of them we have already discussed. So in conclusion, Charcot foot in diabetes patient is increasing as a result of high peripheral neuropathy, and it is very common in Africa and even Asia. Charcot arthropathy can lead to a severe deformity, disability, and amputation. It is very important that the patient with diabetes should seek an immediate medical care if symptoms or signs appear and avoid dealing in seeking medical attention. Early diagnosis of Charcot foot is very important by health workers for successful outcome. Warm to the touch, redness, localized swelling with tenderness in the feet are the key findings that might help to recover the Charcot foot. And this is my last slide. Thank you very much. And I leave with this message. Willing is not enough. You must do it when you go on Monday. Knowing is not enough. You must apply this to the patient. Thank you very much.
Thank you very much, Abbas, for this wonderful, wonderful talk. Charcot foot is the main issue for all of us, and for all the healthcare professionals, I may say, in general. So I think the hand is yours. I need to hand over to you again. Yeah.
Thank you, Maimuna. Thank you very much. And the questions can be put into the question answers and we'll discuss in the end. So now we come to the second speaker, and I'll be honored to introduce her. So Professor Felicia. She's a professor of medicine and endocrinology, diabetology. She's a member of West African College of Physicians, fellow of National Postgraduate Medical College of Nigeria, fellow of American College of Endocrinology, and a fellow of Royal College of Physicians, London. Faculty of Clinical Science, University of Abuja, and an honorary consultant teaching at University of Abuja Teaching Hospital. Felicia is a member of governing board of University of Abuja. Currently, she is also president of Diabetic Food Nigeria, board member of Pan-African Diabetic Food Study Group, and a Nigerian representative of Deep Food International. Her topic today is, does diabetic food care education really works or not? Welcome, Professor Felicia.
Thank you very much. Thank you very much, Dr. Abbas. Thank you very much, Dr. Abbas, for the kind introduction. My topic is, does diabetic food education work? Of course, we know diabetes is a group of metabolic disorders characterized by hyperglycemia, but is one of the greatest epidemics of the 21st century. We're all familiar with this slide from the International Diabetes Federation, that by 2045, we have this large number affected by diabetes, and 1 in every 2 with diabetes is not diagnosed yet. So we have a time bomb in front of us in Africa, particularly countries that run an out-of-pocket system. I am always saying the cheaper option we have is prevention always. We can see that we have, the tendency to have 143% increase in the prevalence of diabetes. This is quite scary for us in Africa and also Nigeria. This was a prevalence study done by one of my colleagues, Uloko et al., looking at the prevalence of diabetes in various regions. And we can see that the highest we have is South-South region with 9.8%. Okay, and North Central 3.8%, Northeast 5.9%, Northwest 3.0%. So the percentages differ depending on the region that we are referring to in Nigeria. We are also familiar with the various complications of diabetes, particularly when control is very poor. 60% of non-traumatic lower limb amputation occur in diabetes patients more than 20 years old. The diabetic foot. Diabetes is a silent disease until the onset of complications, and the complication of diabetes with very high economic cost is the diabetic foot. The prevalence of DM foot in Nigeria is 8.3% to 19%. An amputation rate can be as high as 53.2% in some centers. The lifetime risk of a person with diabetes developing diabetic foot is 25%, and 15 to 20% of patients with foot ulcer will subsequently require amputation. Diabetic foot is the most common cause of non-neoplastic non-traumatic amputation of the lower limb extremities. Of course, we all know that greater than 1 million amputations are performed per year on diabetes patients. But what is very scary is to know that every 30 seconds, a limb is lost to diabetes, and 4 out of 5 ulcers in diabetes patients are precipitated by trauma. Now, diabetes and the foot in Nigeria. In Nigeria, diabetes care is being carried out at the primary, secondary, and tertiary levels of healthcare. In many centers, either there is no education at all about, basic foot care, or it is provided too late for these patients. Many patients with foot problems present to the tertiary healthcare facilities at the stage where 50% of the time, the only option we have is amputation. So diabetes foot in Nigeria constitutes a major medical, social, economic, and psychological burden to the patient, the healthcare system, and the public in general. So what's our experience in the University of Abuja Teaching Hospital? The price of no food education. This is 5 illustrative cases to show the consequences of when we see patients and we don't educate them. Mr. OM, a 32-year-old male architect, known diabetic for 8 years with poor drug compliance. He had a right foot ulcer, which started as a blister in his big toe and managed it at home for about a month. When we examined him, he was obese, of course, with a BMI of 35, hyperpigmented edematous right foot with multiple discharging sinuses, and he came with a blood sugar of 22 millimoles. Now, Mr. SS, a 49-year-old male, was a police officer, known diabetic for 7 years, presented with a 3-week history of right foot ulcer, which started as a boil, later was treated after self-manipulation, and he had had a previous ulcer on the left foot. He had a BMI of 29, previous healed ulcer on the left foot, ulcer on the medial aspect of the right foot extending to the base of the big toe and medial malleolus. Blood glucose at presentation was 30 millimoles. Mr. AE, a 60-year-old male engineer, known diabetic for 22 years, hypertensive 5 years, came with right foot ulcer for 2 months, resulted from a wire that pierced his foot at a building site. He had a BMI of 32, multiple sites on the plantar surface of the foot, discharging pus with gangrene of the fourth toe. Dorsalis pedis posterior tibial vessels were non-palpable. Blood sugar presentation was 23 millimoles. Mr. IK, a 45-year-old custom officer, known diabetic for 7 years, he presented with a 3-month history of right foot ulcer, started just as a blister, and he had a history of wearing of tight-fitting boots for 8 to 12 hours most days of the week because of his job. And we can see the way the foot, presented. Mrs. OV was a 67-year-old retired female teacher, known diabetic for 7 years, hypertensive 2 years, also presented with a 3-week history of darkish discoloration of the left foot and leg, had intermittent claudication unattended to for about 3 years. So these 5 illustrative cases were all educated people, learned people, an engineer, an architect, a police officer, a custom officer, a teacher, and so on, but they were never informed about, by healthcare providers about foot care education, the possibility of developing diabetes-related changes in their feet. So both ulcers and amputations have enormous impact on people's lives. So does foot care education work? This was a paper published in 2020 from the University of Abuja Teaching Hospital. And research has shown that the impact of DM foot education leads to an increased patients' awareness on the prevention of DM foot disease. DM foot education reduces the risk of lower limb extremity amputations and mortality as well. So the aim of our study was to assess the impact of diabetes foot care education on self-care and practices amongst our patients accessing care at our teaching hospital. The methodology was this. It was a pre and post education study design carried out within a 1-year period. The education program was based on the Diabetes Education Training Manual for Sub-Saharan Africa by IDF. Healthcare staff had seminars and workshops on diabetic foot prevention and management for 3 days. Patient education was carried out by trained diabetes nurses and doctors at diagnosis and reinforced at follow-up clinics. And it included simple foot care advice, daily examination of the foot, foot hygiene, how to perform pedicure and usage of, footwear. And also they had IEC materials given to them. And the results, 155 diabetes patients were studied. The tool was a questionnaire designed with 2 sections, demographic characteristics and the knowledge of foot care. At the end of 1 year, the same questionnaires were administered to assess the impact of DM foot education to healthcare staff and the patients. Data was analyzed and the ethics committee, approved the study. Now, a total of 155 patients were studied, 64% were males and 91% were females. The mean age was 49.3 and the age range was 40 to 80 years. And the mean duration of diabetes was 6 plus or minus 2.6 years. 76, that's about 49% of the patients had positive family history of diabetes. Now, this is to show us, sorry, let me minimize this so that we can, this is to show us the knowledge of patients with diabetes food, the food care knowledge and practice and the frequency. Now, we see here that only majority of the patients, about 46.5%, had the knowledge that trauma from animals or sharp objects or improperly fitted shoes, can cause diabetes. But other aspects, their knowledge was very poor. Now, the pre-hospital care that our patients prefer when they have problems with their food, we found out that 8% will not take any action at all. About 37% will do home dressing, and 20%, well, if there's a nearby nurse, they will go to the nurse. About 3% will rather do hot water soaks. About 11% will prefer herbal treatment, and 21% will go to chemists for whatever they can offer them there. This was comparing the knowledge before and after of these patients. And after 1 year, we found out that 84% of them were empowered as regards what to do with their foot as diabetics. Also, this is assessing the knowledge of healthcare professionals, examining the feet of patients. And we found out that at the end of the program, more doctors will actually look at the feet of these patients as compared to before the program. This slide is quite exciting to us because over the years, with the impact of education, we found out that the admission rate and amputation rate gradually reduced in our setting. In 2017, we had large number of admissions because of referrals from other centers to the teaching hospital. This was another study we did in 2017, looking at the outcome of patients with diabetic foot, just to show the initiating injuries for our patients who have diabetes foot. Majority are spontaneous blisters that they now tamper with at home. Some of them falls, nail puncture, pedicure. We have a few patients who come with diabetic foot and even gangrene after pedicure in the salons, ill-fitting shoes, animal bites. Sometimes those who keep antelope, they have antelope bites or rat bites and so on. And then some result from fissures. So in Nigeria, diabetic foot remains a major cause of morbidity and mortality, occurring in 32.2% of all diabetic admissions in our center. And we have seen the mean age in developing countries, including Nigeria, apart from neuropathy and vasculopathy. There are other factors that exacerbate diabetic foot, which include walking barefooted, animal bites, educational status, and socioeconomic status. The research has shown that DM patients who receive intensive foot care education have greater reduction in the number of foot problems they have as compared to those who have not had education. And at the end of this education program, 84% of the patients got empowered. In developing countries also, there's a common belief that traditional management is more effective than modern medicine. This is one of the factors that contribute to delay in making positive impact through education in amputation prevention. The chance that the doctor will examine the patient, like I said, increase. In the University of Abuja Teaching Hospital, we have a multidisciplinary diabetes foot care team that has resulted in significant decrease in our amputation rate from 50% in 2009 to 10% by 2017, which is the lowest in Nigeria so far. So our experience in the study has shown that continuous foot care education can improve foot care practices in DM patients, prevent ulcers and amputations. Our patients feel let down by healthcare professionals for the lack of early foot care education. When DM foot care education is offered early, it's the easiest, least expensive, and most effective way of preventing foot ulcers, amputation, and death, particularly in our setting where we run an out-of-pocket system. We need specialized multidisciplinary foot clinics for a more organized and better care. Podiatry and orthotic services are very essential part of this multidisciplinary team that we need to begin to introduce and encourage. These are my references. Now, this is just to show the training we had, the step-by-step training we had in Nigeria. Dr. Abbas was there. We can see him beautifully standing with the Minister of Health then for the program. And he had a book that the Minister of Health in Nigeria, actually presented and launched for him in that program. This is also showing him active, during our workshops that we had. So thank you very much. Thank you very much.
Yeah, thank you very much, Felicia. This was a fantastic message from Africa. It was an excellent, really. I always say the only tool we have it in Africa is education. You've shown it. This is really a very clear message. Thank you very much. And we'll discuss further during question answer.
Thank you very much.
Right. Now coming to the another speaker from Africa, Professor Memuna. She is, and I have privilege and honor to introduce her. She is a professor of medicine at University of Dhaka with over 20 years of experience in metabolic and endocrine disease. She is currently head of internal medicine unit and director of National Diabetes Center in Dakar, Senegal. She is also a specialist in public health and has an extensive experience in Africa and Europe in the area of research, good clinical practice, management of diabetic foot and other complications of metabolic disease. She is a regional representative of Diabetic Foot, D-Foot International for French-speaking Africa, and also a representative of her country. Today, she's going to talk on diabetic foot in French-speaking Africa. Welcome, Muna.
Thank you very much, Abbas, and thank you, Felicia, for this nice talk as well. I'm happy to talk about diabetic foot in French-speaking Africa, and I'm happy of the title is for French-speaking Africa, knowing that generally problems are the same from one country to another, and we definitely need to work together to find common solutions that are adapted to our context. So this is the agenda. I would like to say something briefly about the epidemiology before coming to the clinical particularities, our challenges of diabetic foot care in Africa, and then expose some solutions and perspective. So starting with the epidemiology, we are all aware that diabetic foot has a very heavy impact in Africa, as 80% of amputations seems to occur in the developing world. So the burden of the diabetic foot in Africa is difficult to evaluate due to scarcity of data. We know that, diabetic foot ulcers are a major source of morbidity and a leading cause of hospitalization in patients with diabetes. But as I said, lack of data makes it very difficult to get policymakers' attention so that they can develop policies to prevent and address the increasing burden of diabetic in our population. The epidemiological surveys suggest that Africa has the second highest prevalence of diabetic foot ulcers among diabetics. And available data show similarities concerning the very high rate of amputations, which range from 20% to 50% in Togo, with a consequent mortality rate of up to 60%, often due to sepsis. And diabetic foot care also consumes up to 15% of resources in developed countries and up to 40% in developing countries. For example, in Senegal, one amputation has been evaluated to cost $2,500 US. And this is not counting with indirect costs such as the suffering, loss of autonomy, loss of productivity, which are very difficult to evaluate. Coming to the clinical particularities, as we can see, the age of occurrence is relatively young, 53 to 55 years compares to 65 in Europe. And our patients usually come very late to the consultation, often at the stage of gangrene. The investigations are not done systematically, and this results in suboptimal care. And this is high. We see our patients at a very late stage with severe lesions, and that result in high percentage of amputations and death. And we also see, particularly in countries where we have many Muslims, this uncommon localization of callus, you see, and this is due to the Muslim, the position of Muslim during prayer. Africa is also characterized by a high rate of infections, 70% in Togo, 97% in Senegal. And this is the leading cause of amputation in 25 to 50% cases. So challenges are many. Sub-Saharan Africa faces challenges due, first of all, to patients themselves. Because there is a lack of awareness of food care issues. So these patients seek medical care very late, as we already said. There is a big delay in seeking timely medical care because they fear the amputations. They believe that coming to the hospital is equivalent to being amputated, and also because they have bad lifestyle habits. For example, walking barefoot is very common in our countries. Ill-fitting shoes are also largely used, like these that we see also in Maghreb, or these kind of shoes that do not protect feet. So that's why they get ulcerations like this due to trauma. And we all know that ill-fitting shoes are the most common cause of ulceration. Also, non-compliance to offloading. We will probably come back to that in the questions with Abbas, who exposed how to take care of the kind of neuropathy like Charcot fever. But this offloading is very difficult to be accepted by our patients. And also, this phenomenon that you can see in many African countries, we have largely in Dakar, for example, what we call street podiatry. So patients who do not know their status of glycemia, whether they are diabetic or not, often do that kind of care in the street. You can see the instruments are like on the street, and that exposed to ulcerations and infections mainly, and also the fact that patients seek for traditional healers first. These traditional healers are very competitive and they treat everything: diabetes, hemorrhoid, dysfunction, erectile dysfunction, and everything. So there are also challenges from the health system perspective. And these are observed also in many parts of Africa. The absence of training programs for healthcare professionals. For example, in none of our country, there is a training for podiatry. It doesn't exist. So this also explains delays in referring patients with serious complications for specialist opinion, because these untrained professional healthcare professionals are not also aware of the food issues. So there are also the lack of the concept of team approach. So people are not trained to food care management, and they do like they feel it, and this results in many complications as well. So this just to say that there is a need. Let me just come back to this one. There is a big need for specific emphasis on diabetic food education for healthcare providers. The capacity of our healthcare providers to manage diabetic food is uneven in different countries. And MDs often are better capacitated than other healthcare professionals, such as nurses, nurse practitioners, medical officers, and non-medical personnel, to diagnose and treat diabetic food. And this leads to misdiagnosis or inappropriate management. So what are the solutions and perspective? Here we just want to share some success stories, taking examples what we have done in Senegal. We focus a lot on education in food care. Again, Abbas, we fully agree with you that education is the less expensive and maybe one of the better tools that we have in our possession. So we focus in education for the patients. And we also focus on training of healthcare professionals. And here in Senegal, we have developed a partnership with a podiatry school in Ghent, Brussels. And this allows us to train our healthcare professionals, because these students come every year, 2 to 3 students come from the podiatry school and then spend 2 to 3 months in our service to train the healthcare professionals. We have done training on testing techniques, for example, the use of monofilaments, and also on offloading techniques. And thanks to Christine Fanaker, who visited us many times, we have been able to train in many parts, to do the training in many parts of the country, and so to increase the number of healthcare professionals capacited in food care. We recently, last year, during the World Diabetes Day, we did the launch and distribution of the D-Food info cards, with here the Director of Health in Senegal and the WHO representative who attended the ceremony. And we had our first podiatry room in 2007, and now we have just finished building the extension of the podiatry room to do offloading. We still collaborate with local cobblers, local shoemakers, and we intend to equip this room with the help of D-Food in order to provide proper offloading to our patients. We also have many programs like the e-diabetes program. The e-diabetes program have been launched many years ago, and it's an innovative and low-cost prevention program via mobile phones, via internet connection that allow to train healthcare professionals in remote area. And we have this M-diabetes program, which is used to raise awareness and do digital coaching to patients. We just send them small text messages to raise awareness on diabetic food. And we have tried a tele-expertise program to show them, to show healthcare professionals how to take care, give an advice on how to take care of diabetic food when they send us pictures of their patients. So at the regional level, what has been done is first the Train the Food Trainer program. This Train the Food Trainer program took place in December 2008, and 6 sub-Saharan African countries have been able to participate: Burkina, Congo, Gabon, Mali, Senegal, and RDC, and 3 Maghreb countries. And all participants were assigned
Memuna, we can't hear you.
using new technology of information and communication are known to be valuable options to increase diabetes awareness and prevention, and also to train healthcare professionals in our context. And this is largely used by all those who attended the program. So topics include fundamentals of food examination, risk stratification, also basic management of ulcers, and there are video demonstrations on practical gestures. And these are useful tools to be used to train HCPs, especially in remote areas. So we are all aware that in our context, there is no doubt that to address diabetic foot ulcers in sub-Saharan Africa, we will require robust healthcare system able to diagnose, treat, and provide chronic care for the diabetes patients in general, and for diabetic foot in particular. So we really need a trained workforce, and we intend to develop that more and more with the help of D-Food International. Thank you for your attention.
Thank you very much, Memuna. This was an excellent overview. Fantastic. And I'm very happy. You touched everything. Thank you very much. We'll discuss it later on. Okay, thank you. Coming to the next speaker, we had these 3 lectures on research and education and giving you overview. And now 4 speakers, they are going to mostly talk on the challenges, barriers, and way forward. So we had this idea from beginning that we should have both from each region. So my next speaker is Helen. She's an associate professor of medicine, consultant internist endocrinologist. She is from Addis Ababa University, Ethiopia, and at the moment she is also working in Rwanda with University of Rwanda and Ministry of Rwanda. Welcome, Helen, with your talk. You are most welcome. The floor is yours.
Thank you, Dr. Abbas, for the introduction. And I would like also to thank the organizers for making a day to talk about diabetic food in Africa. In my presentation, I'm going to go through the experience we had in Ethiopia, and specifically at Addis Ababa University College of Health Sciences, Black Lion Hospital. So as an overview, Ethiopia is an East African country with a population of more than 110 million. And IDF estimates the prevalence of diabetes in Ethiopia to be 3.2%. And this is similar with STEP survey that was done in 2015. But some studies in urban settings have shown as high as 6.5% of diabetes prevalence in urban setting. When we look at the healthcare system in Ethiopia, it's a 3-tier healthcare system, I think similar to most African countries, with primary, secondary, and tertiary healthcare. And Ethiopia launched the national NCD strategy, including for diabetes in 2015, and has been developing training manuals, giving trainings to especially primary and secondary healthcare workers, trying to organize non-communicable disease services at primary and secondary health settings. But when we look at the service availability and readiness studies, which was published by the Ethiopian Public Health Institute in 2018, only 46% of healthcare facilities were ready for diabetes, and 34% were ready for cardiovascular disease. So this is just a survey of availability and readiness, not even service provision. That's way beyond below the percentage that's shown here. So when we talk about diabetes food care, it's in the context of the service availability, the trained healthcare professionals who are trained to give comprehensive diabetes care at each level of healthcare settings. So when we come to the Black Lion Hospital, which is a teaching hospital for Addis Ababa University, we did like a food audit in patients with diabetes. And in 2015, we found that only 4.5% of patients had a food exam during their follow-up in our clinic. And this number increased to 23% when we did another study in 2017-18, which is a good progress, but it shows we have still a lot to do in terms of doing a food exam or a food exam being a routine in our clinic who come for diabetes follow-up. And in another study, we were trying to see what are the diabetic food risk ulcers in our patients, and 15.5% of our patients had a previous ulcer, 35.5% had at least one risk factor for ulceration, and the reason for admission of type 2 diabetic patients to our hospital has been diabetes with ulcers with complications in almost 40% of the cases. And these patients, more than 50% of them presented with late stage of the Wagner staging, so which is similar to the presentations the previous presentations. So it's I think the same across Africa. And mortality rate in these patients was 21%, and amputation rate was 47%, so close to 50% of our patients ended up with major amputations. So when we look at the challenge of diabetic foot care, I think, again, I'm going to do the presentation just to emphasize our challenge. They are not different from my colleagues, but in general, again, I would like to emphasize that it has to do with the need for shift in healthcare priorities in our settings, because we have a primary healthcare focused healthcare, meaning focusing on communicable disease and maternal and child health, and not addressing the non-communicable disease in general and diabetes in particular. And we need up-to-date data on prevalence and related complications of diabetes in Ethiopia to help plan and prioritize our programs. So when we look at the challenge, I would like to look at them as the healthcare system, healthcare provider, and society. So this is what I summarized from different publications that were done in Africa and also in our setting. So as I said earlier, our main challenge seems to be a primary healthcare focused healthcare system with less attention to non-communicable diseases, including diabetes. There is no organized non-communicable disease diabetes care, shortage of healthcare professionals who are trained to give care for NCD and diabetes. There is non-existent podiatry services across Africa, and the fragmented diabetes foot care. So even in our hospital, which is a tertiary care hospital, and we were trying to organize a diabetic foot clinic, we still have problems in terms of organizing a team consisting of physicians, nurses, surgeons, or orthopedic or general surgery, vascular surgery, podiatry, or podiatry is non-existent. So we were trying to work with physiotherapists if we could adapt to make them work with us in developing foot shoe wears or offloading devices for our patients or psychologists. So we need to move toward teamwork in the care of patients with diabetes and also diabetic foot ulcer. And there are no training programs which are continuous, and we do training programs, but they are intermittent. They are not organized, continuous to make sure that we train the key opinion leaders in foot care, prevention, treatment, offloading, but also we refresh, we supervise what's happening in our healthcare settings. And also Ethiopia is a big country, so we need to train people from across Ethiopia. And shortage of medicine, including antibiotics, dressing materials. We use still gauze and maybe saline to clean the wound. So we don't have the appropriate dressing materials. We don't have the appropriate offloading devices to treat our patients who come to us, or even the devices that we have to use for prevention in patients with diabetic foot disease. When we look at the healthcare providers and challenges related with healthcare providers, again, lack of awareness, which is because of lack of training, and also motivation. So I believe the only physical exam that meaningful physical exam we do during patient follow-up is maybe look at the feet. We do vital signs, and the other is education. So we can emphasize that if we can do at least an annual foot care exam for our patients, we can save a lot. If we do education and also screening of risk, screening of existing problems. So sometimes patients come to the clinic with an ulcer and they may not tell you, or they might have fungal infections and you may not see it unless you ask the patient to remove the shoe and look at the feet. There is delay in referrals, so patients do come late, but also once they come to a healthcare setting, the referral from a primary healthcare setting to secondary to tertiary healthcare setting is delayed making the patient have more complications, infections, gangrene, resulting in amputations and poor outcomes. When we look at the society, again, the low literacy level of our society, poverty, the low health-seeking behavior of our population also contributes to the poor outcomes in diabetes foot patients. So this is to share with you what we have been doing at my hospital in Ethiopia, the Black Lion Hospital. So we started training doctors and nurses to the International Interprofessional Wound Care course in 2012 when I started my fellowship in endocrinology. And this happened through a link we had with the University of Toronto. We had an academic collaboration with the university, and one of the endocrinologists was involved in a diabetic foot project in Guyana, and they wanted to do the same in Ethiopia. So through Professor Gary Sebald, which is a lead in the project in Guyana, and his team made several trips to Ethiopia since 2016. So they have done 4 on-site trainings to our nurses, internal medicine residents, and endocrinologists, surgeons, and orthopedicians in diabetes foot care, and also wound care trainings. And we have established an equipped foot clinic at the diabetes center, which is found at the Black Lion Hospital. So we did a renovation of the clinic to change it to a foot clinic. So we were lucky. We have a separate building for diabetes, and we were given 2 rooms to be used for a foot clinic. So we opened a foot clinic with some equipment which were donated from the Banting and Best Diabetes Center in Toronto. So after training of the key opinion leaders and also training of our staff, then our future plans are to roll out to other hospitals and also cities in Ethiopia. We have already started it by training the internal medicine residents who come across in Ethiopia and go back to their respective hospitals. And also in Addis Ababa, we have different hospitals, and we have internists and also fellows who come from the other hospitals, and we make them part of the training so that they go back to their hospitals and be advocates and open diabetic foot clinics in their hospitals. And then we were trying to create awareness, also doing conference presentations and publications of our experience at our hospital. And this is one of the presentations we did at the IDF in 2017, sharing our experience in international collaborations in improving diabetes foot care. In conclusion, I think we have been making some efforts to address diabetic foot problems in Ethiopia, specifically in Addis Ababa, and so far it's promising in terms of we have motivated healthcare professionals who would like to take the training and do the clinics. We need, for strengthening mainstreaming and scale up, we do need to train more people. We do need equipment, we do need advocacy to do it, and also more funding for, again, training equipment, dressing to do the work. And we are looking forward to the South-South and North-South collaborations and partnerships. I think there is a lot of experience across Africa, and we can collaborate and partner to build on what we have been trying to do. Finally, thank you to you, and also I would like to thank the people who were coming to our hospital for the training. Professor Gary Sebald, Dr. Julia Low, Hiski Smart from South Africa, Gulnaz Tariq from Abu Dhabi, Brahat Kotur from India, Sunita, Laura Lee, Heather from Toronto, and to all my colleagues back home. Thank you.
Thank you very much, Helen. That was a nice, excellent presentation from giving us an overview of eastern part of the Africa. Helen is also a wound specialist, and she usually doesn't mention that, but she also is a part of International Wound Society. Okay, now I will give to Maimouna to proceed with two other speakers. Maimouna, can you take over the floor?
Yes, yes, of course. Abbas, I'm happy to introduce the next speaker. It is Mesmin Deayam. Mesmin is a lecturer at the Faculty of Medicine and Biomedical Sciences, University of Yaoundé. And he's also a consultant physician at the Endocrine and Diabetes Service of the Yaoundé Central Hospital, Cameroon. He's the national coordinator of the project Changing Diabetes in Children in Cameroon. And Mesmin is also going to give us an overview, a quick overview of what is going on in Cameroon. Mesmin, the floor is yours. Thank you. Please turn your audio on. We don't hear you.
Okay.
Okay.
Okay. Thank you, Maimouna, for this kind introduction. And I want also to thank Dr. Abbas and all the organizers for giving me this opportunity to talk about diabetic foot in Cameroon. I don't know what's happening. Okay. So Cameroon is a country situated in the Central Africa in an area called Gulf of Guinea. So the population was estimated to be 25 million inhabitants in 2021. The country is poor, and that is why you can see that only 1/3 of households spend less than $570 a year. And also there is a problem to have access to good quality of care. In terms of insurance, we have only 5% of the population that have a health insurance. Concerning the prevalence of diabetes, according to Diabetes Atlas 2019, the prevalence of diabetes was estimated to be 6% of adult population, giving the total number of persons with diabetes counts to be 615,000. And concerning diabetic foot, the prevalence was estimated to be 12 or 13% from two hospital-based studies. But I'm sure that the real prevalence will be lower. So just to give an idea of the diabetic foot in the country, we talk about the prevalence. And concerning admission in our service, that is the bigger endocrine diabetes service in the country, the number of people admitted for diabetic foot is 13%. So it's lower compared to what was presented in the Abuja Teaching Hospital in Nigeria. And concerning the amputation rate, also from this patient, it was estimated to be 16%. So 13% of admission, 16% are amputated, and amongst those people, even the death rate is also estimated to be 11%. But what I didn't mention here is that the majority of our beds are occupied by patients that were admitted for diabetic foot ulcer, so they stay longer in hospital. We have also evaluated the amputation, the death rate among patients that undergone a major amputation, and we realized that it was very high. 35% died during admission, and after the amputation, the cumulative death rate at 1 year was 46%. But we also see that after the first year, when you follow patient, the death rate does not increase so much when we look at the survival curve. Probably because the majority of patients that are amputated are due to first of all, as the Professor Maimuna showed, the age of patients that are amputated is lower compared to what we'll find in Western country, but also because the comorbidity are not too much, and the majority of patients are dying because of infection. We have also looked about the germs that are responsible of the infection of diabetic foot ulcer in our environment. Many studies have been carried out, and we realize that gram-negative bacteria are predominant and are highly resistant to commonly used antibiotics. This is really a great problem because other antibiotics that are really sensitive, like amikacin, is expensive and also can be toxic, and imipenem are expensive, and if they are largely used, will also lead to development of resistance. And concerning risk factors, peripheral artery disease is present in 80% of our patient consulting in our diabetics clinic. So what are the barriers challenging concerning diabetic foot care in Cameroon? They are not different from what we'll see in other African regions. So there's lack of center or services specialists, first of all, in diabetes and diabetic foot care. There's lack of trained personnel in diabetic foot care. So the number of diabetologists is limited. We don't have nurse educator, nurses. There are some pediatrics, but they are not working in diabetic center. Also, many surgeons are not really comfortable to give good quality of care for a patient with diabetic foot ulcer. So the tendency for some is just to amputate in situation where we can really save the limbs. There is absence of training program for healthcare professionals, lack of awareness of foot care issue among patients and healthcare professionals. It has been mentioned that, for example, from Ethiopia, that the majority of our patients don't have these annual foot care exams and also are not educated. This is not the case from our hospital, but usually when patients are admitted for foot care and you interview them, you realize that majority of them never been examined, never had a foot exams and also education concerning the prevention of foot ulcer. There's delay among patients in seeking timely medical care or among untrained care providers with serious complications. We also mentioned the poverty of the majority of patients with diabetic foot ulcer, and this will explain the delay to consult the appropriate services. And even when they are in our services, they are not all, since they have to pay they have to pay themselves for healthcare. There's this delay of good care, and this will explain complication, prolonged stay in the hospital. There's also some local malpractices, for example, scarification of the feet, and also by traditional healer. Also, there are situations where some patients have developed foot ulcer because traditional healer was using hot water to to treat foot pain that were related to diabetic neuropathy. In what has been done to improve the situation, I will mention further creation in our service, a diabetic foot clinic at the Yaoundé Central Hospital in 2010. This really helped us to improve the quality of care for our outpatient presenting with diabetic foot ulcer. It was also possible to reduce the stay in the hospital for patient admitted for diabetic foot ulcer. We also use this clinic to train healthcare professionals from other centers in diabetic foot care. Concerning the training of healthcare professionals in diabetic foot, many workshops have been organized in the country, but also our healthcare professionals have participated in training, in workshop, or even in training for diabetic foot care. For example, Dr. Abbas has the opportunity to train one of our nurses. We also have opportunity to send some of them in South Africa. Lecture on diabetic foot care are done for medical students during their training. Concerning awareness of foot care issue among patients and healthcare professionals, we are regularly organizing national sensitizing campaign using media. We also regularly in our center organize education session on foot care for our patients in our center, but also in some centers that are run by the patient association. So to conclude, the management of diabetic foot ulcer remains a big challenge in Cameroon. The prognosis of patients with diabetic foot care remain poor, and many undergoing amputation and some die. Early diagnosis of diabetes, proper management of diabetes, screening and education of patients with at-risk foot is essential. There is a need to increase the number of specialized centers in order to increase access to foot care and also lower the cost. There is also a need to have more funding in order to improve our activities. Thank you very much.
Thank you, Ms. Min. Thank you for this nice overview on Cameroon. We are handing over to the next speaker. The next speaker is Dr. Yampabo Sanya. He's an assistant lecturer in endocrinology at the University of Nati Boni in Bobo, Dioulasso. Dr. Sanya, if you are ready to share your screen, the floor is yours, and we will kindly ask you to stay on time in order to allow us to finish with the last speaker and allow some discussion. You can start, Dr. Sanya. Please turn your microphone on.
Okay, thank you for this. I'm here a little. Hello?
Okay, we can hear you. Yeah, we can hear you. You can start.
Hello?
Please go ahead, Dr. Sanya. We see your screen and we can hear you. There's some echo, but we can hear you. Go ahead. Dr. Sanya? You can start.
Okay.
Sanya, just switch off your video. Switch off your video. Your internet is not all that okay. Unmute, Dr. Sanya. Unmute. Unmute. You're muted.
Sorry. Sorry.
You can turn off your video. Your internet is not
So
always
I'm talking about the overview of diabetes in Burkina Faso. Sorry? Sorry, do you hear me?
Yeah, you can switch off your video. Switch off your video.
Okay.
Il faut fermer votre vidéo, ça vous... Voilà.
Okay. Okay, so the prevalence of diabetes in Burkina Faso among adult people is about 5.5%. And in the urban area, this prevalence reached to 12%. About diabetic foot, we have not the exact prevalence of this, but it's about 14% of all diabetes-related hospitalization with a monthly incidence of 3. And the other characteristic of diabetes foot in Burkina Faso is the severity, as about 70% are classified as stage 3. I can't move the slide. Okay. For the research done in on diabetic foot in Burkina Faso, we have 3 main research. The first is about the bacterial microflora of diabetic foot infection. And in this research, we show that about 88% of cultures are positive. And between the microflora, we have an aerobic gram-positive cocci, about 76%, and aerobic gram-negative bacilli, about 24%. Between aerobic gram-positive cocci, we have Staphylococcus aureus and Streptococcus sp. The last, the 2 other research are about antibiotic susceptibility of bacteria isolated from diabetic foot infection. And we show that gram-positive cocci are highly sensitive to amoxicillin and acid clavulanic or oxacillin. We show no methicillin-resistant bacteria, and Enterobacteriaceae are susceptible to imipenem and ticarcillin. About the becoming of diabetic foot, the DFRAT is about 33%, and the amputation of a lower limb segment is about 53% of our patients. So what are the barriers and the challenges? The main barriers is about population are not sufficiently informed about the risk factors of diabetes and about diabetic foot. The second main barriers is about the delayed consultation, because our patient still present late to the management of patient. Donc this is some pictures you have. For example, for a patient who came late with this severity of lesion. And the other barriers is about the cost of the management, because diabetic foot care is very expensive for our patient, and we have no government funding. So in Burkina Faso, in the 2 major hospitals, we start with basic training of nurses and general practitioners on the management of diabetic foot infection. Then we have a week program 1 or 2 times per year. by the Internal Medicine Society of Burkina Faso, and this program is supported by the World Diabetes Foundation. And we start to implement a little diabetic food care unit in the internal medicine department of two major hospital in Ouagadougou and in Bobo-Dioulasso. But you still face to a lack of equipment. And this is some picture of some diabetic food unit with, as you see, lack of equipment. So to conclude, diabetic foot reach almost 25 of all diabetes-related hospitalization in Burkina Faso. Then we can see the end stage of lesion. Most of infection can be successfully treated with a standard antibiotics if seen early. We have no government funding, but we try progressively to setting up a microcare program to face of this diabetic foot arise in our major hospital, and we try to training general practitioner, nurses, and surgeons on the management of diabetic foot in Burkina Faso. Thank you.
Thank you very much, Dr. Sanya. We have great hopes that you will succeed, all of us. May I hand over to you, Abbas, to introduce the last speaker before we have some discussion with the audience. Thank you. Unmute, Abbas.
Thank you very much, Maimuna. That was very nicely done. Thank you. You are welcome. We covered eastern part of the Africa, central, western, and now we are going to the southern part of Africa. And Dr. Brown Kamanga is from Zambia, who is a lecturer and endocrinologist at the University of Zambia. And he's going to talk on diabetic foot in Zambia. Dr. Brown? And your slides are ready.
Please unmute, Dr. Brown.
Dr. Brown, can you unmute and unmute?
Shall we show the
good
slides?
afternoon. I can see the screen now. Good afternoon to all. I hope you can hear me.
Yes, carry on.
Yeah, go ahead.
Yes, please. Sorry about that. Yeah, so Zambia, as you know, is in southern part of Africa, and it has a large surface area, over 752,000 kilometers squared, with the commercial capital called Lusaka, which houses the largest hospital, which is the teaching hospital and the main referral hospital in Zambia. For diabetes in Zambia, it has been increasing. The prevalence has risen from 3.4% in 2000 to about 7.2% in 2017. And this is attributable to the sedentary lifestyle, consumption of energy-dense foods, and that hospitals or health facilities are currently as close to the people as possible. Therefore, people are able to seek medical care early. Next slide, please. Regarding diabetes foot ulcer disease and research, I should say that there are several audit reports and institutional studies that have not been published. So this is gray area information on diabetic foot ulcer disease. However, in 2015, Dr. Mangwato and colleagues noted that 75% of the amputations that were carried out at UTH could have been prevented. So it requires early reporting to the health facilities by the patient, and then the health facilities must have the knowledge to diagnose and investigate as well as treat these conditions to prevent amputation. In the audit reports, for example, in 2000, we had about 690 patients with diabetes-associated amputations at our hospital, UTH. And in 2010, this reduced, and we were happy that we are succeeding. But again, 2017, we saw a rise in the number of people being amputated. Next slide, please. So there are challenges which cut across Africa or developing countries. First, our people must be educated. They are not educated on diabetes, and the healthcare providers are also not many that are educated on diabetes as well as on diabetic foot ulcer disease. And the funding to the diabetic clinics or diabetic associations is erratic, and therefore funding for diabetes foot ulcer disease prevention and management is also very, very unavailable. Diagnosis of diabetes is possible to do. We check the fasting blood sugar. We are rarely able to check to do oral glucose tolerance tests. HbA1c is not in many centers. And due to these difficulties in diagnosing the condition, the difficulties in staging diabetic foot ulcer disease, we find that this is very challenging for us. The number of trained specialists in endocrinology, diabetology is very, very small. We do not have trained vascular surgeons, podiatrists, diabetic nurse educators to help in this fight against diabetes and diabetic foot ulcer disease. And we therefore remain with one option for the treatment, which is amputation, the most common treatment modality that is being employed. Regarding diabetes foot ulcer disease, we do not have scientific studies to guide national policy. Maybe this also does explain the reduced amount of money kept for the management of diabetes and diabetic foot ulcer disease. As we know, knowledge is important. Yes, we must have evidence, yes, so that the funding can go to areas with evidence. And the Diabetes Association of Zambia, which has the objective to educate the masses in Zambia about diabetes, is not funded by government directly. They have been funded in the past few years by the Norwegian Diabetes Association, and of course, they could not or they are unable to achieve all their objectives. Next, please. So what are the interventions in place? We have diabetic clinics in our major hospitals. However, these are poorly equipped with the personnel. They are poorly equipped with the equipment. Therefore, they are not doing much. They would have done better, well looked after. The government hospitals and private hospitals ought to invest in the diagnosis, prevention, and management of diabetes and its complications, including the diabetes foot disease research, management, and the treatment. However, I'm happy to inform everyone here that recently we have formed a group which is going to carry out diabetic foot disease research in Zambia. This group comprises general surgeons, registrar surgeons, specialist physicians, and endocrinologists and nurses to help know more about the profiles of diabetic foot ulcer disease in Zambia, their outcomes, and therefore reposition ourselves or better position ourselves going forward. So in conclusion, I would say that the care of both diabetes and diabetic foot ulcer disease in Zambia desires more. For improvement, we need scientific knowledge to guide the management of these conditions, to help us strategize on prevention and treatment. And we need to formulate policies definitely based on what studies show, so that we are better informed and we allocate our resources properly. Thank you very much.
Thank you very much, Dr. Brown. That was very nice and clear, and you gave us a clear message. What is the status in Africa? I have few questions which have been passed to me. Dr. Professor Felicia, there's a question to you if you are around. What are the factors which leads to delay presentation in Nigeria setting? Felicia? Okay. Memuna, let me, yeah. Yes, Felicia, carry on.
Okay. 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 So, well, in apparently from listening to all the presentations, we have common denominators in Africa. Finances is one big factor, particularly, like I said during my presentation, countries where we run an out-of-pocket system. You know, and we know that management of diabetic foot is expensive. So when the patients affected don't have the resources, they don't want to come to the hospital. I showed a slide of the options that our patients prefer. Many of them stay at home. Many of them go for herbal treatment. Some of them go to a chemist shop and all that. It is because they are afraid of how much it's going to cost to get to the hospital. So finances is one. Of course, ignorance is another, because sometimes it may not even require so much, but if we educate them, like I have demonstrated in the study that we did, if we are able to empower them, then they are able to be in charge and prevent having challenges with their feet in the first instance before we talk about amputation. So ignorance. So it has been emphasized in virtually every training that we need to, virtually every presentation, we need to train both the healthcare providers and the patients themselves. So it's a dual approach that we need to adopt. Train the healthcare providers to be able to empower the patients to take proper care of their feet and prevent having problems with their feet. And then, of course, the policymakers, we need to sensitize advocacy to the policymakers. We need to sensitize them to understand the implication of, poorly controlled diabetes, that it affects virtually every organ of the body, including the nerves, the blood vessels, and the legs. And also subsidizing diabetes care. It is so important. So the policymakers have a strategic role to play to reduce the burden of diabetes and then the complications of diabetes in the African region. Thank you.
Thank you, Felicia. That was very clear and to the point. Yeah, we've been shouting that, and thanks, you've mentioned it again. There is also one question raised by Harry, but I think I'll come there to later before I finish with Memuna. Memuna, there is a question for you, and that's been a hurdle for a very many years. That what are your plans to counterbalance the lack of podiatrists in not only your region but all over in Eastern, Western, and Central Africa? So can you tell us, Memuna?
Oh, thank you, Abbas. Indeed, this is, as you said, a big challenge. And I have to admit that I feel kind of jealous when I travel abroad and I see how much podiatry is developed and there is known in our countries. So thanks to the partnership that we developed with, I told you, some Belgian schools of podiatry, we have been able to set up a project, a new project that will start this January 2022, which is to include podiatry training in the curriculum of nurses at the National School of Nurses here in Senegal. The project will run from 2022 to 2025. And we hope that we will be able to extend it to the neighboring countries, because this is something that is feasible. And I'm even thinking of maybe making a summary and sending it to DFOD. Vijay, I might request your help on that. So that we get help from all the specialists in podiatry to come and give this training in our countries, not only in Senegal. I told it could be in the sub-region in French-speaking Africa, so that we can develop prevention, as you have been advocating for years, Abbas. There are means to fight against diabetic foot that didn't take much, that are not expensive. And these means are education and healthcare professionals training. And we need to focus on that. Thank you.
Memuna, thank you very much. You really made me an emotional. I'm so proud of you. I'm really so proud of you. You made it. I'm emotional by listening to you, really.
Oh, sorry.
Well done. And it should come to us as well. Thank you very much. I've been shouting for ages, and it's really very nice. I just want to add here two more things. There is a project going on in Nigeria. They're going to start a fellowship master's project in diabetes, and it's still under process, but the credibility by all the government institutions has been given, and it will be a master plus diabetic food would be there as a subspecialty. That's number one. Again, that's another one apart from what you said, Memuna. Then another one is there is also a fellowship program in Rwanda, where also 12 specialties would be taken care, and that's in government of Rwanda is going to take care of that. And there also there will be a subspecialty on diabetic foot. So that's wonderful news. Thank you very much. There is another question raised by Harry from Malaysia that what would be I think we already got suggestions and recommendation how to go about. So we definitely need something from international to help us fellow Africans, colleagues in Africa, which has been neglected for ages. Vijay, would you like to comment here, and then I end the sessions?
Yeah, thank you, Abbas. I think there are two things on behalf of DFoot International. We are in a pandemic situation, and the previous board where I was a part decided that we won't have a direct physical train the foot trainer program like we had in Marrakesh. It may not be possible in the next 6 months or even 1 year, because we don't know how the pandemic is going to behave. So what I would offer Africa and all the other low and middle income countries like Southeast Asia, Western Pacific, South and Central America is a webinar based. We have already budgeted it. The DFoot International is already budgeted it. We have the money in a bank in Belgium. So we would be happy to take up webinars, and we have international speakers. We have international collaboration with the IADFS, International Association of Diabetic Foot Surgeons. So we have Professor Andrew Bolton, who's our honorary member. So we can bring all these people for a webinar. I don't think travel is going to take place in the next 6 months to 1 year until the pandemic completely subsides, and we are in the midst of a pandemic. So along with Abbas, we would like to roll out a lot of webinars in all the low middle income countries, Africa, India, China, Malaysia, all the low, Brazil. So we have a very strong board and regional chairs. So we would like to get suggestions from the Africa region. In what way the DFoot International could get associated with you? We have excellent speakers. We have podiatrists in our DFoot International. We have money to do that. So we would be able to do it.
Thank you
Thank you,
very much,
Abbas.
Vijay. Thank you very much, Vijay. That's fantastic. Yeah, and I think we have all the specialty even in our low and middle income countries. I mean, all developing countries have a specialty. Thank you very much. We can use our own specialty with resources from outside, definitely. It's been a wonderful seminar, and I think we are almost overboard, half an hour plus. And I think I would like to thank, in the end, I would like to thank all the speakers who took the time for the busy schedule and accepted the invitation to talk and lecture on this important issue. Thank you very much from my bottom of heart. Thank you very much indeed. I would also like to thank all the board members and regional chairs of DFoot International for working hard to get this program running smoothly, going to be run even more smoothly in other 7 regions. Special thanks to the core team for organizing this diabetic food awareness program. When they were meeting every now and then. Thank you very much to that. Secretarial and IT service provided by the personnel in the Office of President, Dr. Vijay Vishwanath from Chennai, India. Thank you very much, and especially for Selva, Kumar, and Ramaya, who were really all these items which you see and all these things being produced by them. I should like to thank even the sponsors for facilitating this program and making the webinars a reality. A very big thank you for all of you, and I hope you will come forward in future as well and to rescue us, especially from Africa. In future, I would also like that African partnership, if Irvi and Greg are listening to me, they should be also a part of it to sponsor it. Finally, I should like to thank all the delegates because without delegates, these webinars would have not been possible. So a very big thank you to all of you. Thank you very much. And I close the webinar. Thank you very much. Bye.
Thank you. Bye.
Bye.
Bye. Bye, everyone. Bye. Wonderful.